Today we are going to discuss about venous thrombosis. So let's see what are the types of venous thrombosis. There are two types, superficial thrombophlebitis and deep vein thrombosis. Superficial thrombophlebitis is when clot forms in a superficial vein secondary to the phlebitis. Phlebitis means the inflammation of the blood vessel. This inflammation may be a cause for the alteration of the vessel wall, and as a result, clots can be formed. Second type is deep vein thrombosis, where clots forms in deep veins. Now let's see what is thrombus and embolus. Thrombus is a clot forms in the blood vessel and it does not travel with the bloodstream, whereas embolus is a part of the clot break off and travel with the bloodstream. This venous thromboembolism can be fatal if it's stuck up in pulmonary veins or veins in the brain. This will cause pulmonary embolism or cerebral embolism. Now, let's discuss about the pathophysiology of the venous thrombosis. Here it affects mainly three factors: stasis of blood, injury to the vessel wall, that means endothelial damage, and altered blood coagulation. Actually, stasis of blood alone does not cause venous thrombosis. At least two of above factors should affect thrombosis. Now let's focus on each factor one by one. Stasis of blood can affect with immobility and polycythemia. Polycythemia means increase the number of red blood cells in blood, causing blood to be much thicker. Endothelial damage can happen directly or indirectly. Smoking and hypertension affects indirectly for the endothelial dysfunctions, whereas surgery and insertion of catheter directly cause endothelial damage. Hypercoagulability has two sides, as hereditary and acquired. Protein CNS deficiency come under hereditary hypercoagulability, while cancer, obesity, pregnancy come under acquired hypercoagulability. Now, we can easily work out the risk factors for venous thrombosis as we know the pathology of the condition. They are leg trauma, general surgeries, pregnancy, smoking, obesity, conditions causing prolonged bed rest like MI, heart failure, and sepsis. Inherited coagulability, for example, protein CNS deficiency. Now let's move to the clinical manifestations. Pain and swelling, especially in the calf of the lower limb. Mild pitting edema of the ankle, dilated surface veins, stiffness of calf, low-grade fever. This low-grade fever occurs especially in pulmonary embolism. Signs of pulmonary embolism: pleuritic chest pain, hemoptysis, and SOB. Now let's move to the investigations. Venous duplex non-invasive test for visualization of thrombus, radioactive fibrinogen, RF testing. This RF administered via IV line and images taken through scanning at 12 to 24 hours as radioactive fibrinogen get concentrated at the area of the blood clot. Venography. This radio contrast agent will clearly visualize the vascular tree and obstruction can be clearly identified. Coagulation profiles: PTT, PTINR, circulating fibrin, protein CNS, prothrombin gene mutation. These coagulation profiles detect coagulopathies. Management. Goal of the management: prevent propagation of thrombus, prevent recurrent thrombus formation, prevent pulmonary emboli, limit venous vascular damage. Here management can be discussed under two subparts as pharmacological and non-pharmacological management. When we come to the pharmacological management, for deep vein thrombosis, we can use mainly two drug groups. They are anticoagulants and thrombolytics. Anticoagulants reduce the expansion of the already existing blood clot, inhibiting the fibrin formation but do not dissolve it. Examples for the anticoagulants, warfarin and heparin. Thrombolytics dissolves the existing clot. Examples, streptokinase. Warfarin inhibits vitamin K, leading to the inhibition of vitamin K depending clotting factors 2, 7, 9 and 10. Warfarin has an indirect anticoagulation action as it does not act directly on blood but through by a liver. Patient who is on warfarin should be monitored with PTINR. It is a teratogenic drug. Warfarin has delayed onset of action when compared to heparin. Heparin is a parenteral direct anticoagulant as it directly stimulates naturally occurring anticoagulant antithrombin 3. This stimulated antithrombin 3 inhibits activated factors 9, 10, 11, 12 and 2. So, heparin can use in emergency management. Patient who is on heparin should be monitored with APTT. We all should know the antidote of warfarin and heparin. Antidote of warfarin is vitamin K and antidote of heparin is potassium sulfate. For DVT, we administered unfractionated heparin and low molecular weight heparin. Unfractionated heparin has a less predictable effect, may be given IV followed by 3 to 6 months oral anticoagulant therapy. Monitoring is must in this management. When talking about the low molecular weight heparin, can given through subcutaneously. Patient can self-administer at home, given in isolated DVT or pulmonary embolism. Monitoring is not a must. Now we come to non-pharmacological management. Early mobilization, elevation of affected extremity. It should be elevated at least 10 to 20 degrees above the level of the heart. This will enhance venous return and reduce swelling. Compressions with stockings, dry heat, warm bottles and heating pads, moist heat, hydrotherapy and warm compressors. Surgery, thrombectomy, removal of thrombus from the blood vessels, placement of a filter into inferior vena cava to prevent pulmonary embolism. Complications. When we talk about the complication, this venous thrombolism can lead to pulmonary embolism and post-phlebitic syndrome, that is also called post-thrombotic syndrome. It is chronic venous sufficiency following DVT. Here we can get 3 nursing diagnoses: acute pain related to the decrease of venous blood flow, risk for bleeding related to anticoagulant therapy, impaired physical mobility related to pain and imposed treatment. Now let's see what are the nursing interventions. Elevate affected extremity to enhance venous return and reduce swelling. We discussed it before. Apply warm compressors or heating pads to promote circulation and reduce pain. Avoid use of aspirin during anticoagulant therapy to prevent further risk of bleeding. To prevent bleeding, we should handle the patient carefully while positioning. maintaining pressure on IV site at least for 5 minutes, and most importantly, observe carefully for the bleeding signs. We should observe for hematuria, presence of blood in urine, melena, presence of blood in stool, hemoptysis, bleeding gums, and epistaxis. So thank you for watching. Please subscribe my channel.